Cast is now starting. All attendees are in listen-only mode.
Good afternoon, and welcome to the Cure HHT webinar series. I am Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT, and I want to welcome you this afternoon to our webinar, Tangled Web of HHT. Just a few reminders before we begin. Today's webinar is being recorded and will be posted on our website. After the webinar, you will receive an email with a short survey. Your input is critical to the development of future webinars, so please take a few minutes to complete this. To help reduce background noise, everyone's phone or microphones have been muted. So to ask questions throughout the webinar, go into the gray panel on your screen and type your question. I will ask as many questions as time allows during the second half of the call. Also, you'll notice in that panel that there is a section for handouts. You can download the documents to your computer during the webinar, or they will be available on the recorded version on the website. And we ask that you please keep your questions general so that we can benefit everyone with the answers. Now, it is my pleasure to introduce our speaker. Dr. Scott Trerotola is co-director of the University of Pennsylvania HHT Center and Division Chief of Interventional Radiology at the University of Pennsylvania. He received his medical degree from the University of Pennsylvania School of Medicine, followed by residency and fellowship training at Union Memorial Hospital and Johns Hopkins Hospital, respectively. Dr. Trerotola has been involved in the care and treatment of HHT patients for over 20 years, with particular interest in pulmonary arteriovenous malformations and HHT. I now pass the program over to Dr. Trerotola.
Well, good afternoon, everyone, and thank you so much for joining us. We're going to be talking about PAVMs today. So really, the tangled web is in all over the body, but in this case, we're going to focus on the lungs. Please excuse me, I've got a little bit of bronchitis, and so if I cough, just bear with me. So a PAVM is a pulmonary arteriovenous malformation. So it's in the lung, pulmonary, connects the artery and the vein, and it's a malformation or that tangled web that we're talking about. So when we see somebody with HHT, and we're talking mostly about their PAVMs, we start with a history and physical examination and offer genetic testing. And what we're doing is we want to try to limit the life-threatening morbidity associated with HHT. The two things that are really going to hurt somebody in the short term are cerebral AVMs and pulmonary AVMs. So we get a brain MRI and we do a workup for PAVMs. And then if they're there, we treat them as appropriate, and I'll get into the nuances of treating PAVMs. We're also going to treat the non-life-threatening manifestations, including nosebleeds, that's epistaxis, with general measures as well as more aggressive measures such as laser and septal dermoplasty, and obviously gastrointestinal bleeding and blood loss associated with that. So the first step in the workup of a PAVM is a contrast echocardiogram. This is the so-called bubble study. We try not to use the term bubble study because people are afraid of bubbles, and in this case, it's deliberate. The injection is just salt water that's shaken up to make some micro bubbles within it, and injected into the veins while the heart is being looked at with the ultrasound of the echocardiogram. I'll just play that again. So here are the atria, the front chambers of the heart. This is all the bubbles right here. And you see some bubbles coming through here, just a few bubbles, and then a slew of bubbles coming through here. This is what we're looking for, the late passage of bubbles, which indicates that there's a PAVM. If they come through early, that could be a hole in the heart, a hole between the two chambers of the heart, or the four chambers of the heart. But what we're looking for is that late passage that we saw here. And if we see that, then we know that we've got a PAVM, and we're going to pursue that with CT scanning. Now, if somebody's got symptoms, we're going to go ahead and bypass the echocardiogram because we know they've got a PAVM, and we need to look at that more directly. Now, one of the things that's really changed in the last couple of years is the way we use echocardiograms. This is a fascinating and very, very impactful study that was done just a few years ago. In this group, what they did is to look at the graded echocardiogram. So the grading, as you can see, goes from no shunt to grade 3. And they, with that grading, which is based on the number of bubbles that are seen during the study, they showed that if somebody had a grade 1 or a grade 0 or no shunt echocardiogram, then they didn't have any treatable size PAVMs. That's what this 0 is right here. And then if they had a grade 2, about 1/4 of them had PAVMs. And if they had a grade 3, about 3/4 of them had PAVMs. So this is potentially going to allow us to use the graded contrast echo to say, hey, if you're grade 0 or grade 1, we don't need to actually do a CT scan. And this is something, it's a very exciting area, both in terms of screening, but also in terms of follow-up after treating PAVMs. Now, once the echo is positive, then we move on to a CAT scan. And there's really no consensus based on the type of CAT scan to be done. There's a non-contrast or no X-ray dye, which is the recommendation on the international guidelines. And the reason for that doesn't have anything to do with the imaging, because the imaging is actually better if you use contrast, but it's really because of fear of getting getting air into the bloodstream. These two scans here on the right both show air bubbles that were injected accidentally during CT scans in patients that didn't have HHT, and this is normal. We see this a lot of the time, and as I'll show in a little bit, the lungs filter out those air bubbles, but obviously in somebody with PAVMs, if those air bubbles go through the PAVM, they could cause a stroke. But what we do is we take very careful care to make sure that there are no bubbles in the connection between the IV and the injector. And if we do that, we can very safely get a contrast a contrast CAT scan, in other words, one with the X-ray dye, and that gives us more information about the PAVM, not only initially, but also during follow-up. So we do, at our Center of Excellence, we do use contrast CTA, that's a CT arteriogram, to look at patients with a positive echo. And we like to see all three components. We like to see, and I'll show you a picture of this in a second, the feeding artery, the sac, and the draining vein to be absolutely certain that we've got a PAVM. Now, there's something that's been out there for a long time, is the 3 millimeter rule, which is something that people have used to try to figure out which PAVMs to treat. And this is something that dates back over 25 years ago now, to a small study that was done at Yale by one of my, Mel Rosenblatt, who was actually a fellow with me at Johns Hopkins. And they looked at a small number of patients, and they showed that patients that had a feeding artery of 2.9 millimeters or higher were more likely to have evidence on an MRI of a prior stroke. And that kind of became known as the 3 millimeter rule. Well, that was based on old data, and the technology has really changed. And if you talk to people in centers, they now treat PAVMs with feeding arteries of 2 millimeters and larger, and that's actually acknowledged in the international guidelines with the statement at the bottom that it may be appropriate to treat feeding arteries as low as 2 millimeters. And really that change came on the basis of a number of reports, including 2 from our center, where patients had strokes with feeding arteries less than 3 millimeters in diameter. And that makes perfect sense, because obviously we can have small blood clots or bacteria that go through those small feeding connections and still get neurological events. So these are called paradoxical emboli, and what a paradoxical embolus is a clot or bacterium that doesn't get trapped by the lungs but gets into the arterial side of the bloodstream after it gets through the lungs. Clot forms in our body all the time, in our legs and elsewhere, and bacteria enter the bloodstream a lot. They actually enter the bloodstream when we brush our teeth, even more so when we go to the dentist for a cleaning or for dental work, and also when we get colonoscopy, especially with biopsies. And the lungs serve many roles. They put oxygen in the blood, but they also filter the blood. Our bloodstream is a big pump system, and all pump systems need filters. The lungs are that filter for us. Well, a PAVM is a hole in that filter. So diagrammatically, and these diagrams are actually in the handout that you can download, you can see that a normal capillary bed, that we have the blood coming from the veins, which remember it goes into the lungs in what are called the pulmonary arteries. So in the lungs, the arteries are blue. They go into the capillary bed where the vessels get as small as the size of a red blood cell, where those bacteria and blood clots get filtered out, trapped by the lungs, and then processed and don't go through here to hurt somebody. But if you have a PAVM, you have an abnormal connection between the artery and the vein. This is the feeding artery. This is where we measure that 2 or 3 millimeter diameter right there. This is what's called the sac, and this is the draining vein. We don't really care too much about the size of the sac. This is the area we care about right here, the feeding artery diameter. Well, you can imagine if you've got a feeding artery that's 2 millimeters in diameter and a 2 millimeter blood clot comes along, goes through right here, it doesn't get filtered out by the capillary bed. The next stop is it goes back to the heart and then it gets pumped out. If it goes to the brain, it'll cause a stroke. If it goes to other areas of the body, it can also cause different things, including heart attacks if it goes to the heart, or dead bowel if it goes to the intestines, etc. So the type of symptoms that people get most oftenly, if they get a symptom, would be a stroke or a mini stroke called a TIA. But you can also get a brain abscess or infection. That's where bacteria go through the PAVM and set up in the brain. People can cough up blood, but that's very rare. This is sort of one of those rare complications that seems to show up in papers and books about PAVMs, but it's really very, very uncommon, and it's sometimes difficult to differentiate that from a nosebleed. You can also get unusual infections such as bone infections or osteomyelitis, and people get heart attacks or angina. We have 6% of patients in our population had either a heart attack or angina as a result of paradoxical embolus with no coronary artery disease. When they're large, the blue blood is not getting oxygen into it, and so it goes back to the heart, still blue, and that can result in exercise intolerance. And when it's very large, people can be cyanotic, or they can have blue lips and blue fingertips. And what you see here, this is a complex PAVM. This has multiple feeding arteries and one or more draining veins, and you can see it just looks more complicated than the simple PAVM that we see here. But most often, PAVMs result in no symptoms whatsoever, and that's why treating PAVMs is kind of like treating high blood pressure. It doesn't give you any symptoms at all until it's too late and it gives you a bad outcome such as a stroke or even death, and that's why it's so important to look for PAVMs and treat them preventively before they cause problems. So our goals in treating PAVMs are to minimize that risk of paradoxical embolus, and we try to minimize the risk of the procedure as well. Ideally, these are done in centers of excellence because of the large experience there, but we also know that that's also not possible because of people that are very far away from centers or because their insurance won't let them get there. And so then we try to get people to doctors that have experience with treating PAVMs. And really, this is like anything else. The more of these you do, the better you are at it. We also try to minimize the intrusion into patients' lives. In the past, we used to admit patients to the hospital for multiple days on end and bring them down for multiple procedures, but now this is purely an outpatient procedure, and we try to treat all the PAVMs in a single session. And at least in our experience here, if anybody has 4 or fewer PAVMs, we can treat them all in a single session. That's not to say we can't treat more PAVMs in a single session. We've treated up to 17 PAVMs in a single session, but if you have more than 4, we just can't guarantee that you're going to get them all done in that single session. But we also feel that doing this improves participation and compliance on the part of other family members who might be resistant and reluctant to go and get treated, even though they know they have PAVMs or at high risk for PAVMs, because they understand that it's really just a day out of their life, which might actually save their life. Now, there are risks of the procedure, like there are with any procedure. There's about a 1 in 300 chance of having a paradoxical embolus, actually, which is what we're trying to stop, and about a 1% chance of a neurological event, which is usually reversible. That would be a TIA or even a stroke. There's also the possibility of allergic reactions, irregular heartbeats, and one thing to tell your doctor is that if you have something called a bundle branch block, or if you've been told you have an abnormal EKG, tell your doctor that so that they can check that beforehand. There's a little bit of bruising at the puncture site, which is normal, and about 30% of people treated with PAVMs have chest pain, which lasts for about a week, and rarely, very rarely, can last for a long time. And this is a side effect, effectively, of the procedure. The things to expect on the day of the procedure, as I mentioned, this is an outpatient procedure here at Penn. We're going to put a bubble filter on the IV, which is to prevent any small air bubbles from getting into your bloodstream. We're going to use moderate sedation with Versed and fentanyl, so you're going to be sleepy but not completely asleep. The procedure can last from 1 to about 4 hours, depending on how many PAVMs we treat. We have a 2-hour observation after the procedure, and then we ask people to take it easy that night, and then they can resume normal activities the next day, with the exception of avoiding heavy lifting for about a week. This is what an interventional radiology suite or operating room looks like. We have imaging equipment. This is the X-ray machine right here. This is our patient right here lying under this drape. They're kept comfortable with the sedation, as I mentioned. We've got some IVs, which of course have bubble filters on them. And all this here, everything that's blue is sterile. So this is, as I mentioned, this is a sterile area and it's an operating room. In terms of what you would experience during the procedure, you're lying on your back on a special table, which allows the X-rays through it. We cleanse usually the groin area just to the right, just over the hip, and occasionally the neck. We put a drape over and then go ahead with the procedure, which is done with, as I mentioned, with sedation, but also with local anesthesia or some local numbing medicine. Most of the time, it's done by the leg, occasionally through the neck, especially if somebody has a filter in their inferior vena cava. People ask me, is it painful? And it's not. It's that the anesthesia and sedation make it a very comfortable procedure. Many of our patients like to watch the monitor as it's going and ask questions. And at the end, I often hear, wow, that was so easy. And again, this is something that we try and convey to other family members who might be reluctant about coming in and getting it done. Excuse me. So our goals in treating PAVMs are to completely cross-sectionally occlude the feeding artery, and we do that with a combination of devices that I'll show you in a second. But here's what's called a plug. Here are some coils, and the idea is that when we block this artery, the PAVM shrinks away. Now you see that sac that was there is now just a scar, and that abnormal communication between those is taken away. And of course, we also want to minimize the risk of the procedure, and we think that these disposable devices actually dramatically reduce. Detachable devices actually dramatically reduce the risks of the procedure. And most importantly, we're trying to avoid persistence, which is the phenomenon of the PAVM still being there even after we've treated it. And one of the handouts that I gave you shows the different ways that persistence can occur. These are some of the things that we use, and of course you generally don't see these because they're inside you, but it's nice to get an idea of what it looks like. The coils have little dacron fibers on them, and this dacron is very thrombogenic. It causes blood to clot. So the coil itself, which these days is made of platinum, causes a cross-sectional blockage. But again, these fibers, these little hairs on here, also cause the blood to clot, and that clot forms a plug, which causes the PAVM to become blocked off. And there are detachable devices to coils, which some people use, and there are also some things called hydrocoils, which some people use, but right now, at least, there's no evidence that they're any better than the standard platinum coils. These platinum coils are what are called MRI conditional. They're completely safe within MRI, and really nobody uses stainless steel coils anymore. So if you've been treated many, many years ago, you might still have stainless steel coils in place, which can cause an abnormal finding on the MRI, but it's not threatening at all. But if you have any problem trying to get an MRI done, usually the doctor who put the coils into you should be able to provide a letter explaining what kind of coils were done. And we do this for our patients all the time so that they can get MRIs as needed. These are the detachable devices. We used to use detachable balloons, and occasionally I'll see a patient who has had one or more of those in place, but we don't use those anymore. These days we use these Amplatzer plugs, most commonly of type 4 or a type 1, rarely the type 2. And you can see these are screwed onto the delivery system right here so that they're very secure, so that we can put them into this high flow area in the PAVM, test them to make sure they're stable, and then let go of them when we're ready. And so I really do think that these have dramatically increased the safety of the procedure. This is the microvascular plug, which is sort of the newest player to the game. Again, screwed onto the catheter right here, and it's actually got fabric on this little meshwork right here, and that creates an immediate blockage of the vessel, so that we don't even need to put a coil in along with it. We can just put the plug in. And we've shown that when a plug is used one of this type of plugs is used in conjunction with a coil, that we didn't see any recanalization or persistence, which is really good. Just to show you some examples and I'll orient you, these are what are called pulmonary arteriograms. These are injections into the pulmonary artery in the chest. The patient is looking toward us, so this is the left lung, and the head is up here, the feet are down here, left, right. This is the catheter going up through the heart right here. It's a plastic tube about the size of the inside of a Bic pen. And when we inject the X-ray dye, it shows up black. And you can just barely see some of the bones. Here's the collarbone. Here are some ribs right here. And this black X-ray dye is showing us this PAVM. You can see here's the feeding artery. Here's the sac. And as we look here, here's the draining vein coming out of the PAVM. The patient has another PAVM up here. Now we've taken our tube and we put it a little bit further into the feeding artery of the PAVM. And this is again where we measure that feeding artery diameter. And this particular one is about 4 millimeters in diameter. This is the sac of the PAVM, and this is the draining vessel right here. And just some other pictures of that. Here we're putting the plug in place. This is the end of the plug. It's still screwed on right there. And now there's the plug. You can just make out the shape of the plug right there with the end of it right there. And this is one coil on top of it. And you'll notice now that when we inject, we don't see this sac anymore because we've completely blocked off the flow into the PAVM. That's a very good result. This is actually a complex PAVM. So here's the feeder that we treated before. Now there's another feeder coming in from below. Same thing there. We put a plug in conjunction with some coils. And then when we inject here, we can see that there's no filling of this sac right here. So this is a very good and very successful result. Here's another example. We can see that the catheter has been put right in the neck of the PAVM here in the feeding artery. Here's that sac and here's the draining vein. Here's the plug still attached to the catheter and some coils. The platinum has a high atomic number, so it shows up as black to an X-ray. And you see the PAVM is still filled with the X-ray dye now because there's nowhere for it to go. It's just, there's no flow in here now. It's just sitting there and it will get absorbed over time. But the most important thing is the PAVM has been completely excluded. Just a couple of more examples. Here's a patient, again, this pulmonary arteriogram. You can see this PAVM filling right here. And when we inject that, plugs plus coils, this patient has a couple of PAVMs treated here, here, and here. And you'll notice right here, this is in the heart. And this is a very common finding. This patient was thought to have a hole in her heart as the cause of her stroke. And they went and treated that first, something they used to do a lot of in the past. They don't do that much anymore. And when they did that, they found that she still had a positive echo, surprise, surprise. And that's when they found out she actually had PAVMs that were the cause of her stroke and not the hole in her heart. This is me in a younger day, my son Ryan, my father Larry, 3 generations. And it's very common in our practice to see 3 generations. And I'm just about to start seeing 4 generations of patients here. And this is the grandma who was the one actually found last to have PAVMs. That was actually the granddaughter that had the PAVMs first, but you can see her multiple large PAVMs, and she didn't have any symptoms whatsoever, but was at risk for a stroke. If you have a PAVM of this size, you're at 10% risk every year of having a stroke. And so these were treated with, as you can see, successful treatment, no further filling of the PAVMs. Here's the mother, again, some PAVMs here, PAVM right there, some other ones on the right side here. These were all treated with a combination of coils and plugs with a good result. And you can see here, again, another one treated in mom, and this is the youngster who had the worst PAVM that required a great deal of treatment in order to get it under control. This is just a specific area. I don't need to get into. This is a patient that has a lot of different PAVMs, and they have a filter right here in their IVC, and sometimes we can actually go up through the filter, or sometimes, as I mentioned, we'll go through the neck. But you can see here, this is a patient with HHT1, where they have multiple small PAVMs. Everywhere you look, you see a PAVM. I can count at least 10 on this side alone. And we'll go in and we just treat the bigger ones. And in this case, you can see this feeding artery is just about 3 millimeters in diameter. And this one, we put a microvascular plug in. You can see just the plug. We don't have to put coils in. It completely blocks the PAVM. There are the ends of the plug right there, and there's no further filling. You see this whole area is no longer visible. Just another injection there. So our follow-up after embolization, this is what it looks like beforehand on a CAT scan. This particular CAT scan is called a coronal view with the patient looking straight at us. So here's the heart. The head is up here, the feet are down here. This is left, right. We can see some ribs here, collarbone, and we can see the PAVM right there, the feeding artery, the sac, and the draining vein. And this is in follow-up 6 months later. You can see the plug and the coils, and this is just the scar. You'll notice that the vessels are all white. The scar is dark brown right here, or gray, and that's because there's scar tissue there and there's no feeding artery. I mean, there's no sac there anymore. So this patient is completely treated. This patient will have their next follow-up in 5 years after this. Here's a patient treated with a microvascular plug. Here's the sac of the PAVM. So this is an axial CT, so the patient's lying on their back. We're slicing them like a loaf of bread, front, back, right, left. This is the heart right here. Here's the spine back here, and here's that PAVM sac. Here, after that's the plug right there, and you see that the sac is completely gone. These are the two ends of the plug. So this is the desired result just with a plug. So what do we do post-operatively? We'll see the patient a month afterwards and just make sure their puncture site is healed up and manage any pain they might have had. 6 months later, we're going to get a CAT scan to make sure that the sac of the PAVM has shrunk away. And at that point, we enter long-term follow-up. Right now, that follow-up is recommended to be a CT scan, but that could change over time. It may be that we're going to start using echocardiography more, and some centers are already doing that. We do ask patients that they continue to take antibiotics for dental work and colonoscopy for the rest of their life. That is right in the clinical guidelines, clinical practice guidelines on the website of curehht.org, and also on the handout that you can download. We ask that they continue bubble precautions, preferably with a bubble filter, but if they can't get a bubble filter, at least ask the provider who's putting the IV in to do a wet-to-wet connection to make sure there are no bubbles in the line. And we're constantly sending bubble filters out to our patients. If you need one, give me a call. I'd be happy to provide one. As a scuba diver, it kills me to tell people with PAVMs that they can't scuba, but that's absolute. And I've tried to convince my colleagues in pulmonary medicine about this, and they say, no, this is absolutely mandatory. So I'm sorry, no scuba for anybody with PAVMs. And I tell people there are 3 things to remember in their follow-up. One is to make sure that they're compliant with their follow-up imaging. The second is to make sure that they take the antibiotics. And the third is to make sure that they get those bubble precautions, or ideally a bubble filter on any IV they might need. And again, in the handout, there's a package insert from a bubble filter that you can just carry with you. These are also called micron filters, and sometimes that is more familiar to people when you mention them. So our post-embolization care in the Penn HHT Center does differ a little bit from the guidelines. The guidelines mention 6 to 12-month follow-up. We do 6. They mentioned 3 to 5 year screening. We do 5. And quite frankly, PAVM growth is so slow that I think we're going to be stretching that out to 7 or even 10-year follow-up. For people that are echo positive but don't have a visible PAVM on the CT, they recommend a 5-year follow-up is what we do, and we manage this on a case-by-case basis. And we really believe that CTA is used because it's most widely used to look for persistence. As I mentioned, things may change because of graded echo in the future. So some of the questions, and I'm sure we'll go over some of these in our question and answer session, are: will I need more treatments? Obviously, that's going to depend on whether we got everything done and whether there are any PAVMs left. If only coils were used, about 20% or 1 in 5 patients at that 6-month follow-up will need a little touch-up. But if coils and plugs are used, or some of these newer plugs alone, then that chance drops down to low single digits. Another question is, do PAVMs grow? And they grow, but very, very, very slowly, especially small PAVMs that we don't treat. We've done some research this past summer showing that even over a 10-year period, small untreated PAVMs effectively didn't change at all. So our screening recommendations probably need to be stretched out. PAVMs grow very, very slowly. People ask, well, if my PAVMs haven't been treated, why do I have to take antibiotics? Well, even if we treat the visible PAVMs, but there are still small PAVMs that we still can't see. If we took a section of somebody's lung and put it on a microscope with HHT, we'd probably still see small PAVMs. And the bacteria in particular are very, very small, and that's why we're trying to get that bacterial load down as low as possible with antibiotics when people have dental work and colonoscopy. What to do if they don't have a bubble filter? As I mentioned, ask for a wet-to-wet connection. But if you know you're going to have elective surgery in the future, by all means get in touch with your provider at an HHT center, and they'll get a bubble filter out to you. People ask if coils and plugs come out, and the answer is no, they're permanent devices. And people always ask me if they're going to set off the metal detector at the airport, and the answer is no. The actual density of metal, which is what the metal detector is looking for, is very, very, very minimal. Just like your earrings don't set the metal detector off unless they're really big, the PAVM embolization devices will not either. So in summary, PAVMs need to be treated to avoid those paradoxical emboli that we talked about, even when you have no symptoms. This is best done in centers, but it's not always possible for a variety of reasons. And when that's not possible, we want to look for the doctor with the most expertise possible to get that treatment done. These are done on an outpatient basis, usually just needing 1 procedure. And really, word of mouth to hesitant family members is the best way to keep people from having a catastrophic complication, which can be avoided just because of denial and avoidance of treatment. I would like to say thanks to Bob White, who obviously is responsible for this whole great HHT Foundation getting started. He's a mentor and a friend to me, taught me everything I know about PAVMs. Reed Peretz, a co-director in the HHT Center. We work hand in hand to provide the best care for our patients. The HHT Foundation sponsoring today and the absolutely wonderful work that they do, our PennIR team, and really to all of you who are so integral to the HHT Foundation and the great things that we do. We're going to go into the question and answer session here, and you've got some contact information here, including my office number. Please feel free to contact Mary if you want to chat with me. My email here, I'm happy to take clinical emails and just send them your way. And with that, I'm going to send it back to Nicole to moderate the question and answer.
Great. Thank you, Dr. Trerotola. That was extremely in-depth overview of pulmonary AVMs. And as you can imagine, the question board is lit up. But before we start the question and answer, I do want to remind everyone that there is a section for handouts on your control panel. And there will be a few additional handouts on the website on the recorded version of the webinar. So our first question is you mentioned grading of buccal echo tests, and is this something that all doctors are aware of? And if not, how does someone make their doctor aware of this grading and the importance of it?
Well, that's a great question, because even here in our center, I can sometimes have trouble getting the echoes graded. I won't lie. This is something that's really becoming much more well known. I did put the reference on the slides, so the best thing to do would be to get that reference, which should be available from the web. And if not, please send me an email. I'd be happy to share it with you. And if you bring that reference to your doctor and show it to them, they can take it to their echocardiography folks and ask them to grade the echo. It's something that anybody can do. It's just a matter of counting. But it's one of those things that we just sort of have to get people used to doing. In the centers, it's much more readily available.
Okay, great. So another question is, if an HHT patient has micro AVMs, what issues can these cause, and can they be treated, and should they be monitored differently?
Well, so micro AVMs are AVMs that are below the threshold of our resolution. And so there's a little bit of controversy here, because so there is a situation that I mentioned that where we'll have somebody have a positive echocardiogram. Usually that's a grade 1, almost always in fact, and yet their CT scan is negative. And in the past, excuse me, in the past, we referred to those as micro AVMs. Now, we know from some fairly recent research in the last 3 or 4 years that there is a false positive for a grade 1 contrast echo, and that's about 25%. So when we see somebody that's got a positive echo but a negative CT, there's a possibility that that's just a false positive echo. Now, Dr. Peretz and I like to have a friendly gentleman's bet about which is which. And what we do is we tend to err on the side of caution, which I think is wise, and tell people that they should still observe those precautions. In other words, observe the bubble filter precaution and especially the antibiotic precaution, because if somebody does have very small PAVMs, they even though they wouldn't let a blood clot go through, bacteria are very, very small, and they might let those bacteria go through. So that's just something that's, I think, a prudent thing to do, and is very inexpensive. The antibiotics used are very inexpensive and readily available, and very few allergies to those. So I think that's probably the best thing to do. There is no treatment for these micro AVMs, if they even exist, and it's one of those things where we just do serial follow-up, and I would not do that follow-up any more often than 5 years. In fact, I think it probably shouldn't be done any more often than 10 years because of the research that I mentioned, which we'll be presenting at the 2018 Society of Interventional Radiology meeting.
Great, thank you. And someone is asking, do you need one of those filters for IV iron?
Oh, that's a great question. I'm glad you asked, because there are some things that can't be put through those filters. The X-ray dye for CT scans and for MRIs can't be put through them. Blood transfusions and iron transfusions can't be put through them. Propofol, the white stuff that's used for anesthesia during colonoscopy and other procedures, also won't go through a bubble filter. So in those settings, what we want to do is just do that wet-to-wet connection and make sure there are no bubbles in the line.
Great, thank you very much. Do pulmonary AVMs grow more quickly during pregnancy?
Well, one of the things about the HHT world is that there's a lot of stuff that we think that we know that we don't actually know. The evidence that PAVMs grow faster during pregnancy is based on about one or two papers that are about 30 years old, and they have one or two patients each in them. Each of these had PAVMs that were visible on a chest x-ray, so they were very, very large, and they did, in fact, grow very visibly during pregnancy. Now, we think that PAVMs probably grow faster when they get much larger. And so these days, since we treat all visible PAVMs, we don't see very many people that are walking around with those big PAVMs just because we treat them. So I think our experience, at least with the smaller PAVMs, including this study that I mentioned that we've done this past summer, was that we don't really see any significant growth during pregnancy either. There's probably some growth during adolescence, and if looking at the few adolescents that we've looked at where we've got before and after, we do see tiny amounts of growth. We're talking about growth on the order of a millimeter in the sac and not even a millimeter in the feeding artery over the course of 10 years. So these are things that we've sort of bandied about and said this is the way it is, but we really don't have proof of that, and it's going to take some more research to kind of give us a sense of what is right and what is wrong in terms of the dogma we tend to say in this area.
Okay, great, thank you. So the next question is, how are migraines related to HHT?
That's a great question, and I don't think anybody knows. It is interesting that some people, when they get the contrast echo, they get some migraines. So presumably those are micro bubbles that are getting through small PAVMs and causing them to have some vasospasm. Migraines are usually due to spasm of the arteries in the brain, and so presumably those micro bubbles cause that vasospasm and cause the migraine. It's true that I do have some patients who have migraines, and they'll even tell me, I feel like I need to be treated again because I'm getting more migraines. And then I treat them, and their migraines get better. And presumably that's just because we're knocking down the load of bubbles of clot or bacteria or whatever that are getting through. But I don't think we have a direct relationship.
Okay. The next person is asking, could swelling in the legs be a symptom of pulmonary AVMs?
Well, typically not. So swelling of the legs can be due to a couple things. It could be due to heart failure, if it's both legs, and particularly if it's the kind of swelling that pits when you push on it, leaves an indentation. That's often due to some heart failure. Now, the most common cause of heart failure in HHT would be liver AVMs or HAVMs, hepatic AVMs, which occur in about 2/3 of people with HHT, especially in HHT2. And if you have somebody that's got that, they should definitely be looked at by a heart doctor or cardiologist to see if they have any evidence of heart failure. Now, the other thing that can cause swelling of the legs, particularly one leg, but sometimes both legs, is blood clots. And people definitely can get blood clots because blood clots can happen in anybody, whether HHT or not. And that is of great concern because, of course, if you've got a blood clot and you've got PAVMs, then those blood clots may break off. And in addition to the pulmonary emboli that we worry about, we could also get paradoxical emboli that I described going through PAVMs and causing a stroke or other complications. So there's no question that if you've got HHT and you got leg swelling, that's something you want to follow up with your HHT doctor and ultimately a cardiologist about.
Great, thank you. So the next question is, at what age do you recommend a first and follow-up CT scan for children?
That's a great question, and one of the things that I'm really hoping is we hope to see a new set of guidelines in the coming year because it really has been quite a while now since the last set of guidelines. Is some more guidance with respect to kids. One of the problems is that we just don't have that much literature on kids with HHT. The the centers with the greatest experience, Yale and certainly here, and some of the most experienced centers in Europe, don't treat kids with PAVMs. There's a good reason not to treat unless they're severely symptomatic. And the reason not to treat kids with PAVMs is that what happens is, with one of the ways of getting persistence is that even a perfectly well-treated PAVM, as that child continues to grow and the PAVM sac grows away from the coil nest, you can get growth around the coil nest. And instead of it just being one feeding artery, now you have dozens of feeding arteries. I've called this the Hydra phenomenon, just like the Greek mythology and the Hydra, where you cut off one head and now it grows back multiple heads. These are extremely difficult, if not impossible, to treat, and so can really make the situation worse. So again, Yale and I, or Yale and in our center are in lockstep on this, that we believe that we should only treat kids when they're symptomatic. We typically talk about symptoms being saturation below 90%. Obviously, any kind of neurological event, but neither of us, in our experience, Jeff Pollock or myself, have seen a child have a neurological event who didn't also have a saturation below 90%. So if you've got saturation below 90%, then we definitely want to get a CT in that child. We can get the contrast echo, but it's not going to change anything, because we know that we have a high suspicion based on the saturation, because those are people that we're going to treat because we have to. We're only going to treat the biggest ones. We're going to leave the little ones alone and try and get their saturation up and hope for the best in terms of persistence. In terms of just asymptomatic screening, we do not recommend an echo or a CT because it's not going to change the management. There's no harm in getting an echo, but it just, as I said, it's not going to change the management because we're not treating those PAVMs until adulthood. People ask me, what's adulthood? I say, once a child has stopped growing, 17, 18 years old, usually it's a good idea to try and get them in before they get to college. If they're going to go to college, and certainly in that time frame where they pretty much have plateaued in their growth, that's probably the time to get them in and get them treated.
Okay, great. So the next couple of questions really relate to the number of embolizations and coils that a person may have. So I'm just going to give you a couple of different questions. One is there a limit to how many AVMs can be embolized over a lifetime? And along with that, is there a limit to the number of coils that a patient can have over a lifetime? And then the last part of that is, does a large number of coils limit a person's lung function, or do new blood vessels form to accommodate the reduction in lung space?
Well, so new blood vessels don't form, but the good news is that we're born with a great excess of lung capacity. We can get along with one lung just fine. So we have more than 50% excess of lung capacity. And when we do PAVM embolization, we are killing this small piece of lung along with the PAVM, but it's a very, very small piece. So for everything except diffuse type PAVMs, which I'll come back to in a second, I really have never found a patient that had so many PAVMs that we were getting up against a point where we thought that we were afraid to do more because of losing lung. Any PAVM, any piece of lung that's got a PAVM with it is worse than having no lung at all there, because it's actually drawing flow away from from the adjacent normal lung. So you can imagine that just, you're better off without that, even if it means losing a little bit of lung. Now, the one exception to that would be diffuse type PAVMs. Now, diffuse type PAVMs are made up of millions of tiny little connections. They're not like the PAVMs that I showed you. And in those patients, you really can't cure those PAVMs. We can cure the other kinds of PAVMs, simple and sort of mildly complex PAVMs, but these diffuse type PAVMs can't be cured. And not only that, when we treat them, we can get undesirable side effects such as growth of arteries feeding the lungs, which can then can cause bleeding. So if we see somebody that's got a diffuse type PAVM involving a single lobe of their lung or even one full lung, we actually recommend surgery in those patients now. Now, this is a small experience. This is me working very closely with Dr. Stephanie Fuller next door at Children's Hospital, but we've been able to cure a small number of patients who had diffuse type PAVMs isolated to a single lung, even after a dozen or more procedures with hundreds of coils in there, and really not making any headway whatsoever. And so I do believe that in that situation, the best thing to do is surgery. And in fact, we made that recommendation once this week.
Great, thank you very, very much. So we have a couple of questions sort of related to people that don't live near an HHT center, or if they do live near a center, but the center doesn't take their insurance. What should they do as far as, testing and next steps?
Well, let's take the second situation first. So if you live near a center but they don't take your insurance, all centers, including our own, have programs for helping people out with insurance issues and taking people outside of their network and that sort of thing. And we've been very, very successful. And actually, Mary, my administrative assistant, spends a lot of time working on this in getting people in who's even though we're out of their network. It can be done. It just takes some effort. And what we'll try and do is get all the workup done outside. The CAT scan and the echo can be done locally. We can give instructions for how to do it. We can have them sent in to us to take a look at. And then when we talk about getting in to get the actual treatment, that's where the expertise really matters. Then we can go ahead and work to try and get the out-of-network stuff done. If the folks don't live near a center and don't have the ability to travel to a center, then the challenge is to try and find somebody with experience. I think the best thing is always to ask the doctor you're talking with, how many of these have you done? And if they start sort of hemming and hawing, then you probably want to look elsewhere. If they can confidently tell you that they've done a decent number of these, I don't know what that decent number would be, but they've done a few dozen perhaps, then that might be worth taking the chance that they're going to be able to get a good job. And I recognize that, speaking from the ivory tower, we always have to be sensitive to this issue. And as I mentioned, we just spend all kinds of time and effort getting people in from the outside, even though their insurance initially said that they couldn't come.
Fantastic, thank you. I know this is definitely an issue at all centers, and everyone does seem to be trying very hard to get people in. So I would recommend to anyone who is having trouble finding a center near them, or if they have insurance issues, to give our office a call and we can try and point you in the right direction. So the next question is, what exactly is exercise intolerance, and how big does an PAVM have to be to cause this problem?
So exercise intolerance just means that you get short of breath with exercise. Now, of course, there's lots of things that can cause that, right? I mean, that can be just that you're out of shape. It could be that you're overweight. It could be that you have heart disease, and lots of different things cause that. But I see a lot of younger patients with PAVMs, and especially runners. And I'll say, I can't believe that you can run a half marathon with all these PAVMs. They're like, I feel fine. I don't notice anything. But when after I treat their PAVMs, all of a sudden they're like, wow, hey, I can do so much more. So people don't what they think of as being normal, they actually do have exercise intolerance. They just don't know it. I remember one little girl suddenly saying that she could swim the length of the pool underneath the water, which was the first time she'd ever been able to do that. And she was so excited about that. And it was just so gratifying that was after I treated her. It was she now knew what her new normal was. So exercise intolerance is going to vary on a lot of factors, but if your saturation is 90% or 92%, I guarantee you that after we treat your PAVMs, you're going to be able to do more than you could do before, whether that's walk more flights of stairs, do more out in the garden, whatever it might be.
Great. And a person isn't at risk with HHT for exercise. It's just they may feel limited if they have lung AVMs, correct?
Oh, absolutely. No, you can definitely exercise. Obviously, the thing is, if you know you have PAVMs, you need to get treated, right? Because we're not worried about the exercise. We're worried about stroke. And 10% risk of stroke every year if you've got a PAVM with a feeding artery 2 or 3 millimeters in diameter. So that's why we treat them. But if you've got PAVMs that have been treated or they're too small to treat, no, there's no risk to doing exercise. Exercise is a good thing. Everybody should exercise.
Okay. Someone is asking, what is the percentage of HHT patients who have pulmonary AVMs?
So that's a very interesting question. The traditional answer is that about 40% of people with HHT have PAVMs. There's probably some difference between HHT1 and HHT2. With HHT1 tending to have a lot more PAVMs and on relatively fewer nosebleeds and liver disease, and HHT2 having fewer PAVMs and more liver disease, more nosebleeds. But there's a lot of overlap between them. But yeah, traditionally the magic number people talk about is about 40%.
Okay, someone is asking if you could clarify your statement about the size of a pulmonary AVM as it correlates to the chance of a stroke per year. I think you said 10% chance of a stroke.
Right. So, and again, this is not heavily evidence-based, but this is something that's was published by Dr. White many years ago, and it's kind of a number that people continue to quote. Is that if you have a feeding artery of at least 3 millimeters in diameter, because that was the old 3 millimeter rule, I say 2 to 3, you have about a 10% chance per year of having a stroke, if untreated, of course. If you're treated, then that chance is virtually zero.
Okay. And then someone else has asked or mentioned pulmonary hypertension as it relates to HHT. And just wondering if there's any kind of special attention that should be placed on pulmonary AVMs and if there are any known pH drugs that trigger development of pulmonary AVMs.
That's a great question, and one to which I don't think anybody really has the answer. HHT, or pulmonary hypertension is fairly common in HHT. It's more common in HHT2 than HHT1. And it's, we can screen for pulmonary hypertension with an echo. So the nice thing about getting that echocardiogram is we get a, excuse me, we get a free look at that as well. If somebody has pulmonary hypertension, then they definitely want to be under the care of a pulmonary doctor to watch that. To my knowledge, nobody has shown that any of the pulmonary hypertension drugs increase the development of PAVMs, and that really wouldn't necessarily make sense because the way they work doesn't really promote blood vessel growth, and so I don't think we know of anything that necessarily promotes the growth of PAVMs.
Okay. This question is if an AVM is large, like they're saying 4.5, but the feeder is only 1 millimeter, would you leave it untreated or is there more risk of rupture by treating it?
Well, first of all, just to work backwards, the risk of rupture in treatment is very, very low. I mean, the rupture of PAVMs as a complication of PAVMs has been grossly overstated in the literature. And again, if you look at the published events of rupture, it's tiny percentages. It's like under 1% of PAVMs. So that's really not why we treat them. You'll note that I didn't even mention rupture as an indication for treatment. What you're telling me doesn't quite make sense because I don't think I've ever seen somebody, in fact, I know I've never seen somebody with a feeding artery only 1 millimeter in diameter with a 4.5 centimeter PAVM or sac. If we're saying 4.5 millimeter sac, yeah, you could have a 1 millimeter feeder and a 4.5 millimeter sac, and you wouldn't do anything with that because it's under the threshold for treatment.
Okay. Could you explain the difference between HHT1 and HHT2?
Yeah, HHT, and there's a lot of great information on the Cure HHT website about this, but the HHT1 is associated with a mutation called endoglin, ENG, and that is characterized by lots and lots of PAVMs, relatively less liver disease, relatively less nosebleeds, whereas HHT2, which is also called ALK1 or ACVRL1, it's a different mutation. Those folks tend to have relatively fewer PAVMs, relatively more nosebleeds, and more liver disease. To the point where if I see somebody that's got tons of HAVMs, one or no PAVMs, and it tells me they got nosebleeds every single day, I can almost, bet the house and the farm they're going to have HHT2.
Okay. And does the risk of stroke go up with the size of the PAVM?
Well, nobody really knows the answer to that, but it makes sense that it does, because the larger the larger the size of the PAVM feeder, the more likely it is that something is going to be able to get through it. So you're talking about a feeding artery that's 1 millimeter. It won't let anything bigger than a 1 millimeter clot, which may not be likely to cause a stroke. If you've got somebody that's got a feeding artery of 5 millimeters, then that's going to let either a lot of 1 millimeter clots through or up to 5 millimeter clots. And because there's so much more flow going through there, that also means that the chance of any clot going through there is higher. And so there's a lot of different factors that go into that argument that the bigger the feeder, the higher the risk of stroke. But there's not a proven paper out there that shows that that's the case.
Okay. And someone has just mentioned, the normal screening is 5 years as follow-up, but just wanted to mention or ask that if their symptoms change, for instance, if they have shortness of breath, that they should contact their physician in the interim.
Yeah, I think that's always prudent. I will tell you that obviously that happens. I have many hundreds of patients that I follow in my practice, and I definitely get those calls. When we look, it's rare. I'm going to say I'm not going to say never, but very, very, very rare that we find PAVMs that need to be treated. But that change in symptoms may be development of pulmonary hypertension. It could be something else. It could be the development of heart disease or lung disease, or it could be liver AVMs that are becoming more prominent. So yeah, definitely anybody that has a change in symptoms should check with their HHT doctor for further workup. Thank you for bringing that to my attention.
Okay, and someone has asked if lightheadedness could be a possible symptom, and I've had others just asking in general. Could you say again what the symptoms are that they should be looking at for possible PAVMs?
So in terms of, remember, as I said, the most common symptom is none. So that's why it's so important to screen. And really, anybody who is on this call who has family members that haven't been screened, they definitely need to go and get that done, because no symptoms is the most common by far. If you're going to have symptoms, the most common symptom would be a stroke or a mini stroke. Those mini strokes can show up as sudden loss of vision in one eye, sudden difficulty with speech or finding words, weakness of one arm or leg, and drooping of one side of the face. All of those, in addition to more sort of esoteric and more general things. But lightheadedness, as a rule, is not really a sign of a stroke. That's usually more of a sign of maybe of dehydration or getting up too quickly. But really, any symptom that you're worried about, if you know you have PAVMs, especially if you have PAVMs that are untreated, you definitely want to talk to your doctor. And I'd say if you have PAVMs that are untreated, you need to get them treated.
Okay, thank you. And as far as pulmonary AVMs are related to brain AVMs, can you just talk a little bit about just the screening process in general?
Sure. So there's no relationship between pulmonary AVMs and brain AVMs. They occur independently. While brain AVMs occur in 10 to 20% of people with HHT, and actually the neurological complications are actually still more common as a result of PAVMs, just because PAVMs are so much more common than brain AVMs. We do recommend screening in infancy with a brain MRI for brain AVMs, and again in adulthood. So once in infancy, once in adulthood. If you have a brain MRI as an adult that is negative, the present recommendation is that you do not need any further brain imaging, that they don't grow from that point.
Okay. And let's see, I would say that our last question of the evening, because it's almost 5 o'clock, is a CT scan alone sufficient to screen for pulmonary AVMs?
So a CT scan will detect any PAVMs of a treatable size. A completely negative quality CT scan effectively rules out any significant PAVMs. I mean, assuming that the person reading it knows what they're looking at, which most diagnostic radiologists are very, very good at looking for PAVMs because it's something that we learn about in residency, even if we're not in a center. So as I mentioned earlier in the call or in the webinar, there is this situation where you can have a positive echo and a negative CT, and that may be micro PAVMs, it may be a false positive echo, I don't know. So bottom line is a good quality CT scan does effectively rule out any clinically significant PAVMs. Just before we go, I just want to say thank you to everybody for participating. Just watching the numbers on here, it's amazing how much interest there is among the HHT community, and thank you so much for spending this hour with us.
Great. Well, thank you. And I also just want to follow up on two sort of themes. One is there are now 25 HHT centers in North America and over 40 internationally. So if anyone does have a problem getting to a center, looking for screening guidelines, any of that, you're welcome to call our office at any time. Also, information will be on the website for you to download and various resources. The other thing that Dr. Trerotola mentioned was the clinical guidelines, and all of the centers do utilize that, and it was done in 2008, and we know that they do need to be revised, and that is a priority initiative for Cure HHT. And to be honest, it really comes down to funding. So we just really appreciate everyone's support, especially with the annual appeal program that we have going on right now. So just think of us at the end of the year, and we'll try to get that clinical guidelines conference going for 2018. So I just want to say on behalf of Cure HHT, thank you for attending today's webinar. Our shared goal is to advance one common hope, to give those affected by HHT a chance for a normal life. And this webinar series is just one of many ways we accomplish this mission. We are grateful to the donors of Cure HHT for making this happen and all webinars possible. And again, I want to thank Dr. Trerotola for leading us this afternoon, extraordinarily informative. And as I said, his recorded webinar will be on our website along with the downloads that he provided just in the next couple of hours. So we do appreciate your participation, and we hope that you enjoy the rest of your day.